Have you been listening to this breaking news story out of Africa? There's an epidemic, there's a virus infecting tens of millions of Africans across several countries. The virus is uniquely devastating. It disables its victims. It leaves them unable to work or to sleep or to eat. You see pictures of victims looking off into the distance, unable to engage with their peers. For some reason, the virus is infecting mothers more than fathers. So the moms can't take care of their families. Children are left unattended. The media, looking to sensationalize this, has dubbed the virus the zombie virus. There is no cure. Now, as I look at some of your faces, you seem a bit confused. Maybe you've only heard of the zombie virus in Hollywood movies with Brad Pitt, but let me continue. So the big news this morning is that the global community has announced a major effort to counter the zombie virus. They're putting in place billions of dollars for short-term treatments and research for a long-term cure. Experts are confident that in the next few months and years, they'll be able to bring the zombie virus under control. Now, I think some of you would probably agree with me that this is a fascinating story. But some of you are probably also wondering, is this guy making this up? This nightmare is mostly true. I mean, there is no breaking news story, so please don't search CNN for zombie virus after this talk. But this epidemic, this silent epidemic, infecting and destroying the lives of millions in Africa today exists. And like this story, you probably knew nothing about it. The only parts I fabricated were the viral source and the global response. Depression in Africa is this silent epidemic. Depression. It is marked by the most severe stigma, where the ignorance of friends and relatives can lead to a sufferer's expulsion from their family, and where people with this disease have as their only source of treatment local healers, witch doctors. Africa is the last place on earth you want to be a depressed man, woman, or child, where there are tens of millions of sufferers of this mental illness. These people suffer the devastating toll of this disease. But what am I doing here talking to you about depression in Africa? I'm not a psychiatrist and I'm not an African. I'm a Mzungu, a foreigner, as my Ugandan friends love to remind me. But I've lived and worked in Africa for many years, implementing HIV/AIDS programs in the Congo, Rwanda, Tanzania, and elsewhere. And during that time, I saw firsthand the impact of mental illness on men, women, and children. And I was incredibly frustrated by the way that African society treated these individuals and by my own inability to help them. For years, I was another face that looked away while Africans with mental illnesses continued to suffer. And then one day, I was in rural Uganda with my team, visiting a family that we were helping to escape from poverty. And it was a wonderful success story. The family was truly becoming prosperous. The family was led by the grandparents. And after they had finished touring me around their farm, and I was preparing to say goodbye, I noticed behind their farmhouse there was a young man sitting alone under a tree. It was odd. He was out of place. The grandparents told me he was their eldest grandson, that he was sick. Eventually, they admitted that he had been diagnosed with a mental illness. They had once brought him to Kampala, where they had gotten some pills that had long run out. I went over and sat with the young man. He was about 20 years old. He was only wearing a wraparound cloth and was sitting in his excrement. And he was digging in the dirt like this. That's how he spent his days. The grandparents were doing the best they could to take care of him. They had to run a large farm and feed a lot of kids. I tried to talk to him. He couldn't converse. I put my hand on his shoulder and just tried to provide some companionship. I sat with that young man for 5, 10, 20 minutes. I found it so difficult to leave him that day because he symbolized all the mental illness that I had been turning away from for my professional life in Africa. If I left him, I'd be leaving him to what kind of life? My African colleagues were growing increasingly uncomfortable because in their society, someone like this with a mental illness is ignored. I did leave that young man that day, but it was a turning point for me. I left him knowing I had to do something for the mental health of that continent. that young man gave me the courage to try to make a difference for some of the millions of his mentally ill brothers and sisters. So I spent the next year of my life digging deeper into mental illness in Africa and working to start an organization that could truly make a difference. And along the way, I came across some truly startling facts. In the US, we have 9 psychiatrists per 100,000 people. In Africa, they have just 0.05. Well, what does that mean? In Uganda, where they have 40 million people, they have just 30 psychiatrists in the entire country. We have 30 psychiatrists in 2 city blocks of Manhattan. Almost 90% of Africans have no access to effective mental health care. Depression is both the #1 mental illness in Africa and the #1 disabler of their women. So I created a team called StrongMinds to improve the mental health of African women with a specific focus on depression, because that is where we can make the biggest difference. And for me, depression is a deeply personal choice. I have spent my entire life surrounded by this disease. As a child and as an adult, people I know, people I'm close to, people I love have endured and continue to endure this mental illness. I understand the deep pain that depression causes its sufferers and what it does to entire families. But what is depression anywhere in the world? Depression is not sadness. Sadness is a cold. Depression is cancer. Depressive sufferers experience debilitating symptoms. They lack the ability to concentrate, to focus, to work, sleep, and eat well. The science magazine Nature gave an incredibly powerful description of depression on our planet when they wrote that depression is the biggest blight on human society, bar none. And nowhere is that more true than in Africa, where depression strikes those who are most poor. There are tens of millions of Africans who suffer from depression, perhaps 100 million. That's 1/3 of the US population. My team in Uganda knows that 25% of Ugandan women are depressed. That's 3 times the rate here. And the handful of other mental health teams in Uganda can give you similar findings in their countries. Depression harms an African much more seriously than it does his or her counterpart here in the West. In healthy circumstances, an African mother struggles to hold her family together. But when she's depressed, leading her family is nearly impossible. The child of a depressed African mother is more likely to suffer from things like fever, diarrhea, malnourishment, and stunting. He'll also miss more days of school and be more likely to be depressed himself in adolescence and adulthood. An African man, depression robs him of his productivity, reduces his income, and shoves his family into extreme poverty. So depression is not just about the tens of millions of sufferers. It's also about the hundreds of millions of family members, especially children, who depression harms every single day. And if that's not bad enough, these sufferers have no treatment options. There's no social services they can go to. There's no depression hotline. And the local clinic knows nothing about screening and treating depression in Africa. A depressed mom or dad in Africa simply suffers episode after episode, each one further devastating their life. Can you imagine a worse existence? Now, the world ignores depression. Almost no one funds interventions for this mental illness, be it local governments in Africa or global aid agencies. Total funding last year was perhaps about $1 million. There's a number of reasons why. These entities think that interventions are too complex and expensive, requiring billions of dollars and needing psychiatrists and medications that are too difficult to muster in Africa. And then these same entities are impacted by mental health stigma. They tend to look the other way when confronted with the realities of depression. And while they look the other way, depression does not. It reaches out and reduces the effectiveness of the programs these funders do support. When you have 25% of the population that is depressed in many African countries, these individuals do not respond to the variety of development efforts which try to get them to practice safe sex, for example, or follow treatment protocols for tuberculosis. Depression inhibits their ability to focus and concentrate. So the funding development dollars are wasted trying to change the behavior efforts of these depressed sufferers. I think back to a lot of my malaria work in the Congo and wondering why there is always a part of the population who would not respond to our efforts to get them to sleep under mosquito nets to prevent malaria. We would go back and redesign our radio campaigns, but still there was always 20% of the Africans who were not aware of our efforts. And we were just saturating their neighborhoods with radio spots. In hindsight, these 20% were the depressed Africans, and we had no idea they even existed. So we wasted energy and funds literally yelling at them louder in a language they couldn't understand because depression was an impenetrable barrier. And this is happening throughout Africa today. Depressed men and women are not being reached by the basic development approaches of health or job training, and these funds go wasted. But if we address depression first, if we did that, these people would be reached and these dollars not wasted. Now, depression is a silent epidemic. That's the reality. I started today with that fictitious story to help you see that if depression were a physical illness, perhaps a virus, there would be no stigma, and it would likely be addressed by funders and local African governments, and no longer an epidemic, and I wouldn't be standing here talking to you about it. And while there is no virus to spur a global response, I'm so excited to be here talking to you about the fact that there are teams in Africa working on new and innovative methods to treat depression in Africa, and that in so doing, we are beginning to end this silent epidemic. One new great advance that we're working on in Africa is the use of various forms of group talk therapy. These therapies are being used with a high degree of effectiveness in countries like Congo, Kenya, and Uganda. And they're being used effectively without the use of medication. Being able to treat depression in Africa without medication is a huge advantage because these drugs are incredibly hard to reliably procure, and many times these medicines are too expensive for the average African, as you can imagine. Another great advance is using everyday Africans to build mental health care systems in their community. Being able to use these lay people to cost efficiently address the lack of mental health care in their own communities is a smart way to actually use the number of mental health professionals in their community. Because these lay people are trained and then supervised by these mental health professionals. While a small organization, StrongMinds in Uganda, has treated over 1,000 women in the last year using 12 weeks of group therapy. That's entirely delivered by our trained employees who are not mental health professionals. More than 90% of those depressed women were depression-free after the therapy. Our colleagues at Columbia University are actually going to be publishing these results soon. Women in these groups learn how to address and solve their triggers of depression by talking and sharing with one another and developing strategies based on their life experiences. In the process, they form incredibly strong social bonds. So after formal sessions end, these groups continue to meet, and that increases their chances and ability to remain depression-free over the long term. StrongMinds is also learning that when we help people to manage depression, their entire lives improve. When an African mom is no longer depressed, she goes back to work. Her income increases, her kids attend school, and her entire family gets physically healthier. We have this evidence. But to really address the depression epidemic, StrongMinds is working to establish very simple talk therapy groups that go viral and are voluntarily led by African women who graduate from our groups. You have here on the left a StrongMinds therapy group in black, and graduates from that group who are depression-free and trained in therapy go on to form new depression groups. And then graduates from those groups in gray go on to form additional new groups. We're in the early stages of this viral model with several such viral groups already in existence, and we're learning much from them. Our long-term vision is that we'll be able to build these viral groups for depression, and that it'll just cost us a few dollars and perhaps just cents per person. That's much less than the $5 cost for one mosquito net to prevent malaria. The bottom line here is that it's not about us operating groups to prevent depression for the next 20 years. It's about African women operating their own groups. We're teaching these women to fish. As a quick aside, we can use these same approaches here in the US for our own depression problem. But that's a topic for another day. This is Nakafiro Sarah. You would call her Sarah, and I just think that's the most beautiful smile in the whole world. When we first met Sarah, her husband had been missing for 2 years. She was about to be evicted from her plot of land, her small house. She has 9 children and an incredibly difficult life. She sells tomatoes and onions, and as you can imagine, that just doesn't cut it to support her family. All of that means she's severely depressed. StrongMinds convinced her to join our talk therapy group. The change in her life was rapid. The group members helped Sarah to negotiate with her landlord so that she wasn't evicted. These same group members gave Sarah the courage, strategies, and assistance to expand her business and increase her income. Today, Sarah is stronger, better, more independent. Her kids are back in school, and she's no longer depressed. More importantly, Sarah wanted to give back. She wanted to help other depressed women like she once was. She now runs her own depression group, helping her peers to become and remain depression-free. And she does that with our support and supervision. Sarah recovered from her mental illness, depression, and knows how to prevent future depressive episodes based on her group experience. Sarah is one of a new group of people in Africa who can help solve the depression epidemic. And StrongMinds is here to help them. Thank you.